center side. Okay. So, and closer to me. Okay. So when we're going to start out with scapula, anterior, posterior elevation, anterior depression. Okay. With any of the scapular movements, you need to be sure that the person who's laying down, the patient, is in a stable position. Just bend your hips and knees a little bit more. Okay. And what we're looking for is scapular movement, no trunk rotation. Okay, so we're not looking for this motion. Okay, not looking for that. You want, it's the scapula moving on the thorax. You also want to be sure that, as I said, the hips and knees are bent about 45 degrees so the patient is stable, and the head is supported by one or two pillows. You don't want them side bent either direction. Your head comfortable? Okay. Find your scapular landmarks. You want to know where the inferior angle is, superior angle, and around the AC joint. We are not looking to involve the glenohumeral joint at all with this. It could move a little bit, but that's not the emphasis. Okay, so what I say, we're going to do posterior elevation, anterior. No, we're going to start out with anterior elevation, posterior depression. Okay, so what you need to do is understand where his diagonal is. So if, as I said, it doesn't matter where my hands are contacting. So first thing is I need to stand in a diagonal, because if I'm standing here and doing this, it's not going to be appropriate. Okay. The other thing that you need to understand is the scapula moves along the thorax. Okay. The thorax is rounded, it's oval in shape. Okay. So that scapula is not going to be moving straight up and straight down. Okay, it's going to move up and around and down and around. Okay, because it's following the shape of the rib cage. Okay, so here's my anterior elevation. Okay, and I'm looking for the scapula to move towards his right eye, corner of his right eye. Not everybody, some people it might be the bridge of the nose. Okay, and then coming back down, I'm looking for a scapula to move down towards me. Okay, now here's how you're going to tell. Okay, so if I do this and I do this, I'm not getting any trunk rotation. Okay, so I'm going his scapula toward his corner of his eye. If I went scapula to the nose, that would be trunk rotation, not what I want. Okay, so I'm not looking for the rotators. Okay, the other thing that you can look at is the clothing that the person is wearing. Okay, so if I'm going into anterior elevation, I want to see that shirt stretched out nicely, because when the shirt is stretched out, guess what? His trunk is stretched a little bit. And posterior depression, I want to see wrinkles in the shirt, so I'm shortening the trunk. Okay, so if you have somebody wearing a heavy sweatshirt, it's not going to work. Okay, here's what I want you to do: this motion, and then the shoulder blade coming down and back. Okay, up kind of toward the corner of your eye. So now watch my body here and here, okay? Remember, therapist does as little work as possible, right? Use your body weight, okay? So that's the motion. That, what I just did, is rhythmic initiation, okay? Slobbering the input, doesn't matter where my hands are. Passive movement into the direction. So, rhythmic initiation. And you do that, and you're talking to the patient, shoulder blade comes up towards your right eye, and then down and back toward me. So you keep, and you do that maybe 2 or 3 times, maybe 5 times, depending on how much resistance the patient is giving you. Now, so after this, my hand placement is important, okay? So I'm gonna put my hand on the anterior elevation surface of the scapula. Okay, now move up into my hand, and see how I moved with him? Then I change one hand, now push back down into my hand, and I'm moving away. Okay, change one hand at a time, up and forward, and then down and back. Okay, and I'm moving my body with him, up and forward, down and back. So that's where now I'm becoming comfortable with my hand placement and changing one hand at a time. Now, what I don't want to do is up and forward, and now down and back. That's a big, big no-no, because up and forward, then I completely let go and down and back. He's in nowhere land, right? Remember in massage, you're not supposed to break contact? Same deal. Don't break contact. Up and forward, down and back. Okay, yeah.
Can you just say where your hands are?
One hand is over the AC joint, essentially, and the other hand's on top of it.
And then when you move it?
And then, so, then my hand comes down to the inferior angle of the scapula, and my other hand's on top of it. Now, big, big, big beginner mistake. Not getting out of the way of the movement, okay? So I go, move it up and forward, and come down and back. And I'm a block. I don't let them move, okay? Not what I wanted. If I'm gonna give resistance, I'm gonna give resistance at the end of the range. So you have to move with the patient, okay? All right, so that was rhythmic initiation and then reversals. Now I can go, I'm gonna add a reversal and hold, come up and forward, and stay there. And I'm trying to move him back. I'm gonna let go for a minute. Now, when I'm moving him back, I'm moving this way. I'm trying to roll him back. I'm not moving straight back, okay? So hold here, and I'm trying to unroll his scapula, okay? And then come back here, push back, and I'm getting out of the way, hold it, and I'm trying to push his scapula up and over the thorax. Okay? Switch one hand, yeah.
So that movement that he did from anterior to posterior is just a transitional movement and wasn't part of the thing?
Say again? Say that again, I didn't.
Yeah, I don't know if I understood either. So he was in the front and you were pulling back. And then he had to get to the back so you could move him forward. That movement from front to back was just a transitional, there wasn't any resistance in that movement?
No, I was just doing resistance at the end.
At the end, right?
So that was a reversal and hold, or you can call it they call it reversal of antagonists.
Okay.
You can just say reversals hold, okay? Yeah,
Were you gonna say something?
Go ahead.
I was just gonna say, just to make sure that I'm following you right, we did rhythmic initiation, then we did reversals, then what you just did was a reversal with a hold.
mm-hmm. Now, I'm gonna do reversals with resistance. Now, this is, going from, this is increasing the challenge to the movement, okay? So the increase in the challenge is, I'll get to it. Increase in the challenge is first rhythmic initiation, then reversals, reversals hold, dynamic reversals, and then stabilizing reversals, and then combination of isotonics, which I know that you have learned the theory of, but we'll look at it again in practice.
In the reversals,
No, go ahead.
in the reversals, were you helping or
No.
you were just guiding?
Oh, in reversals, I just have my hands there. You can, if the patient needs assistance, you can make it an active assist.
What I was going to tell them. So guys, remember when we did rhythmic initiation, we had a whole pattern of going through passive range of motion to active assisted, and then finally active range of motion. So what Dr. Sofer is trying to say is that when we are doing rhythmic initiation, when we are doing the first component of that rhythmic initiation, that is completely passive. Like what Dr. Sofer showed, hand placement does not matter. You're just trying to get that motion and let the patient understand that. And then we said that when the patient is able to do that, we move to the next component of active assisted range of motion, and that is what is moving towards reversals. So now your hand placement will become important, your cueing will become important. You're going to start doing this active assisted range of motion. Perhaps the patient's not that strong, so you've not even started giving them any resistance, but you're kind of moving them through that active assisted range of motion. And then when you see that patient is able to actively move that whole thing, you know patient is ready for the hold position and start taking some resistance. So that's where comes our hold. Remember we were talking about whenever we do hold, we go slow, we have them, we don't push them, we go slowly, build up that resistance. We do that at the end range. So now the patient can actively move that scapula through that full range. We hold it, build up the resistance, get them stabilized, and then we start moving towards, like Dr. Sofer said, through that bigger range resistance. So we'll move from hold positions to dynamic reversals. Then we are going to build it up to stabilizing reversals and finish it off with, again, a hold at the end position. So that's a complete cycle of using all those techniques. Can you combine that from the previous classes to this class?
Okay. And you can move through any one of these areas more quickly or less quickly, and you can stop. I mean, you might just find that reversal of antagonist with hold, that's as much as you want to do with that pattern, okay? Maybe the patient is tired. Maybe the quality of the movement is deteriorating, okay? Go do something else. You could come back to it. There are no rules, there's no cookie cutter, like you do this 5 times. It's not 2 to 3 oscillations per second for 20 to 30 seconds, okay? It's not that. This is all patient dependent, okay? Much less cookie cutter approach, okay? You can also skip. You can do reversals with resistance. You can do dynamic reversals and not do stabilizing reversals. You can do dynamic reversals and go right to combination of isotonics, okay? whatever you think is appropriate for the patient, okay? Maybe you don't want dynamic, stabilizing reversals. Maybe, it's too much for the patient to be working that hard at end ranges. So, but we're going through it so you get to practice each one, okay? And then, if you practice it, develop an expertise in it, and then you can decide what you need to eliminate for your individual patient, okay? Once you've done scapular patterns or pelvic patterns or when the patient comes back, you may not have to go through the whole thing. Like maybe they already own the pattern, they understand it, so you can start with resisted reversals. Okay? You still awake? I would be asleep if I were in this position. Okay. All right. So now we're going to do we're going to do dynamic reversals. Okay, so bring the shoulder blade up towards your ear, and I'm giving him resistance throughout the range, and now push down and back into me, and shoulder blade up, and down. And now I'm making him work up and forward, and down and back. Up and forward, and you can see where he's working, but I'm resisting with my body weight. Okay, push down and back, and he's working. Now, if I wanted to make it that stabilizing, bring it up and forward, and now come down and back, and now up and forward. I don't let him go all the way. Up and forward, and down and back, and up and forward, and down and back, and up and forward, and down and back, okay, and relax, okay? So that might be stabilizing reversals. Now, what you've all been holding your breath and waiting for is combination of isotonics, okay? So combination of isotonics, you're all right here? Yeah, okay. Combination of isotonics is the most difficult of all of them, of all the techniques, because it's most difficult for the therapist and it's most difficult for the patient, because it has the muscle group in one direction working in all three possible muscle contraction types, okay? So when you're doing combination of isotonics, you choose one pattern you're gonna emphasize, okay? So if I emphasize anterior elevation, okay, I'm gonna have the muscles that do anterior elevation work concentrically, then isometrically, concentric, maintained isotonic, and then eccentric. Okay? Concentric, maintained isotonic, and eccentric of the same muscle groups. And we'll talk about the difference between maintained isotonic and isometric, because I know that's confusing. Okay? So, and I didn't even add stretches yet, okay? So, come here. Okay, bring your shoulder blade up towards the corner of your eye. So that's the concentric. Hold it there. That's the maintained isotonic. And let me bring you back slowly. That's the eccentric. Okay, bring it up. Again, concentric, hold, maintained isotonic, and let me bring you back slowly. That is the eccentric. And it's all the muscles that create anterior elevation that are working, okay? So if this is what I wanted to emphasize, all these muscles, I'm having them work concentric, maintained isotonic, and eccentric. A lot of work for those muscles, okay? If I wanted to do the same thing, posterior depression, then I start him out in anterior elevation, okay? Push down and back into my hand, push down and back, concentric, stay here, trying to move him up and forward, maintained isotonic. Let me bring you up and forward slowly. Eccentric. Again, push back to me. Concentric. Hold. Maintained isotonic. Let me bring you up and forward slowly. Relax. Eccentric.
Yeah, so, in the last class, you had mentioned that isotonics were within intention to move. But would the cue stay here? Or, I would just have one.
So, remember the rebound that we do, so if
So
Dr.
let's
show you
so,
maintained
okay.
isotonic.
So, come up and forward, concentric, hold, and if I let go of the hold, he rebounds, so that's why it's a maintained isotonic.
So his intention is still to move, but because of your resistance, you're holding it. And then when you're slowly having them bring that, you're doing an eccentric hold of the contraction of that whole muscle. We applied the same principle to our trunk extensors. Remember, we were doing a concentric movement of the trunk extensors. Then we held that position. Then we wanted the patient to slowly come forward while I was giving resistance. And we went back and forth. So it's the same principle. We're choosing to apply it on the scapula now.
So now I'm just interested in what you had said before, the difference between the isometric and maintained isotonic, because we learned previously from Dr. Dhaliwal that the verbal cue for maintained isotonic would be don't let me move you,
Yes.
which shows that the patient does have the intention to move, whereas the isometric verbal cue was hold.
Stay here, hold, stay still. Yeah.
So
So if I wanted to do isometric, which is not part of the sequence, okay, but I could, okay, because I can do anything I want, okay, up and forward. Now stay here, don't let me move you. Stay still, stay still. I'm still giving him the same resistance, stay still, but I gradually increase the resistance, stay still, and then I gradually let it go, and there's no rebound. So it's how you release the resistance changes the rebound, okay? So if give me your hand. Okay. Stay here. Don't let me move you down. If I let go, you rebound, okay? Stay here. Stay still. Stay still. Stay still. Okay, that's isometric, whereas the other one was maintained isotonic. Okay?
Always remember, when we are doing isometric, how do we go into the resistance? Always slow. We build it up and we hold it and then we slowly release it. That's the only way to do an isometric. If you're going to do a maintained isotonic, you do have an intention of that person to move. So you're letting them move and then you're holding it. always think of the rebound, that if I let go of this person suddenly, this person is going to do. So it is overlapping. You will probably say at times to them, hold the position, but it's eventually how you're applying your resistance to that person. You can even say, hold, don't let me push you. But just for your clarity, I was trying to teach you that when you say, don't let me push you, your force is much higher. You're really holding that position. But if we say, hold it here, we're really thinking of, okay, I have to go in slow, I have to build my resistance, and I slowly let go such that the patient is able to hold the position there. So, yeah, go ahead.
When you're doing the combination of isotonics, it's to maintain isotonic.
Yes, yes, you're correct. Levy had a question on isometric. So, combination of isotonics, concentric, it's an isotonic movement, the body moves. We do a maintained isotonic. The intention is still to move, but with my resistance, I'm holding it. Next portion is the eccentric, because it's again a movement, but we are combining concentric and eccentric motion, and the combining component between the two is your maintained isotonic. But like Dr. Sofer said, we have extreme powers. We can do whatever we want to do. So if you feel like patient cannot do a maintained isotonic, you might have to do just an isometric hold in that position. But when you think of the combination of isotonic technique, it is concentric motion, maintained isotonic, and eccentric contraction. That's what it is.
So if you're doing COI, combination of isotonics, that's what you do. If you've decided you're gonna do concentric, isometric, and eccentric, that's no longer officially COI. You've just modified it to what your patient needs. It's okay, you can modify it to whatever your patient needs goes, but don't call it COI. Okay, I think it's time to practice. Yeah. And somebody can use this table if